I'm really happy to be here today to talk about Lyme disease. So I'm going to be talking about more of the basics about Lyme disease and some of the complexities of it. And the real reason for talking about Lyme disease at a PANDAS conference is severalfold. One, you want to really include it in the differential diagnosis because there's a lot of overlap between Lyme and co-infections and PANDAS. And Lyme can be a cause of PANDAS. As well as in your treating for Lyme and co-infections, you may really need to be using different antibiotics. So you want to keep that in mind, that just using one cell wall agent like augmentin may not be sufficient if you're treating co-infections in Lyme disease. So Lyme is caused by a bacterial infection by the Borrelia burgdorferi spirochete, and it's transmitted through the bite of an infected tick. And it's important to remember that ticks don't just carry one thing. They're really nature's dirty needles. And it's estimated in some studies that 20%, other studies even as many as 40% of ticks are carrying more than one infection. Maybe 5% may be carrying 3 or more. So it's not just Lyme disease that can be transmitted by a tick bite. One of the ways of trying to expand the definition of Lyme is to, instead of just talking about Lyme disease, to really talk about Borrelia and co-infections. And the co-infections are the other things that are in the tick that you may also get infected by. And there's things like Anaplasma, Ehrlichia, Bartonella, Babesia, viruses, Mycoplasma. All of those things can be in the tick and can cause an infection in a susceptible host. Lyme disease can be transmitted from mother to child. That has clearly been documented, and we'll give some statistics on that toward the end, and also through breast milk. So it's the black-legged tick, or the Ixodes scapularis, on the east coast, and the Ixodes pacificus on the west coast, that are the main carrier of Lyme disease. There are other species of Borrelia that are in Europe primarily and Asia. The Guerinii and Epizeli cause a lot of disease in Europe and Asia. There are 2 other important species of Borrelia that we should mention. One is the Lone Star tick. That's been considered to be something that didn't transmit Lyme disease. It's a very aggressive tick. It bites people very commonly. It's all across the South, from Texas to Florida and all the way north to the Great Lakes, going all the way up the Maine coast into Canada. And the disease that has commonly been caused by that is called STARI, which stands for Southern Tick-Associated Rash Illness. It looks exactly like Lyme disease. It can have an EM rash, a circular rash, but because there were no or very low incidence of the deer ticks, it was felt that it couldn't be Lyme disease. Recently, the Borrelia burgdorferi has been isolated from the Lone Star tick by Carrie Clark in new research out of North Florida. So there may be some other organism within there. It may not all be Borrelia burgdorferi, but it certainly causes a very similar incidence. But because, for that very reason, because before this it wasn't really identified as being the same species of Borrelia, it hasn't been counted in the incidence. So all the diseases with a EM rash in the South with other symptoms that often go with Lyme disease have been ignored and called something else. So they don't fit into the statistics. There's a new report of a type of tick called Miyamotoi, which has previously been found in Japan, and last year was reported as causing illness in Russia. It's a little bit different Borrelia. It's part of the relapsing fever group, and none of our current tests test for it. So the screening test, the Western blot, the PCRs that we use for Borrelia burgdorferi will come out negative with Miyamotoi. There is a new PCR test that Imugen has out that is more specific for Miyamotoi, but this is all brand new. And the estimate is that it may be as many as 10 to 20% of the ticks in the Northeast are carrying this. So someone could have been infected with Miyamotoi and then have it not show up on any tests and be told you don't have Lyme disease. It responds pretty much to the same antibiotics that we use for Lyme disease, although it may be a little bit more difficult to treat and more likely to carry a fever. One thing that's really interesting to just point out about the myomortoi, which may kind of change some of the ways we think about tick infection, is that when the adult tick of the Borrelia burgdorferi lays its eggs, and it's carrying Lyme disease, none of that spirochete is transmitted to the eggs. So all the new ticks are uninfected until they feed on the ground animals. So that would be the mice and the chipmunks. So they have to get infected by feeding on an infected animal. That's totally different with myomortoi. This Borrelia actually transmits the infection 100% to the eggs. So every new tick in the generation is already infected before it even has any blood meal on a rodent. There are two other species that have just been identified as causing disease in humans by the same researcher, Kerry Clark. That's Borrelia americana and Andersoni. So I think you can expect that there's going to be more and more different species. There's over 100 species of Borrelia in the United States. It's genetically one of the most sophisticated of the bacteria ever studied. Syphilis, a common spirochete that we've learned about in the past, has only 22 genes. Lyme has 132. So if you just think of that as a huge increase in terms of complexity. It also has a system where it shares DNA material through plasmids, so it can exchange information among the spirochetes. So it's constantly changing its DNA, making it harder to test for. The incidence in New England, it's concentrated in the Northeast, but Lyme disease has been found in all 50 states. There's pockets in the upper Midwest and in the mid-Atlantic. One of the things that we've realized over the last number of years with the research on Lyme is that it's spread by birds. So the migrating birds can carry it across state lines. So the states that think, oh, we don't have any Lyme disease here, it only takes one bird showing up there that may be carrying 10 or more ticks, and you've got a whole new population started, and the disease starts in a new area. So the myths about there's no Lyme disease in Canada, the birds do cross the border. These things happen. To get some idea of in terms of the number of cases, I think in the past we've really underestimated the incidence. When I looked online to see what the Department of Public Health in Massachusetts was reporting, they gave their most recent date was 2009 with 4,000 cases, and 2005 with about 2,400 cases. I think that's remarkably tiny compared to what we're seeing, those of us who are in the field. The CDC has recently revised its statistics. They've been saying that there are 30,000 cases per year in the United States. In August, they revised this data, and they're now saying there's 300,000 cases per year in the United States. So a tenfold increase that they're acknowledging. And this leaves out the star eye disease, which is all over the South, which is not being reported as Lyme disease. The tick bite can occur at any time of the year. The most active time for the young ticks is May through July. That's with the nymphs, the really small ticks that are like pinhead size. But an adult female tick can be looking for a meal and potentially transmit the disease spring, summer, fall, and even in the winter. If you've got a day that the sun is out and it's above freezing, the ticks are active. So there really isn't, unless you've got a nice cover of a couple feet of snow on the ground, you can get Lyme disease. There have been a lot of different information about transmission, and some of the data that's still out there as I was looking up information for this talk, I found a number of places where they clearly say the tick has to be attached for 24 to 36 hours or you can't get Lyme disease. So if it hasn't been that long, don't worry, just take the tick off, throw it away, and you're done. It's really not true. There are studies that show transmission in as quick as 4 hours after a bite with major encephalitic changes happening. Now, part of this really depends on where the tick bites. If it's on the thin skin in the areas where there's more blood supply, it's more likely to happen quickly. It is true that the longer the tick is attached, the more likelihood you have of transmission, but you need to realize that there's no safe time for a tick attachment. that you have the potential for Lyme disease. So prevention is much easier than treatment, as we know. Once you get into treatment, it's a whole different ball of wax. So the tick habitats are the high grass. They like moisture. They don't like dryness. So keeping the grass cut low, keeping the underbrush cut back, having a 10-foot space before the trees in your yard, all of those things can really help. Some people have chosen to spray their yards with permethrin, which is an insecticide that will kill the ticks in all its stages and makes it safer for kids to play in the yard. It's really important to do regular body checks looking for ticks, especially with young children, because the kids are going to be on the ground and playing. That's the nature of kids, and you really don't want them not to be able to do that. But you have to check them diligently, and really to check behind the ears, the head, the neck, groin, all areas. If you know you're going to be outdoors in a place that is high likelihood of ticks, wearing clothes that are pre-treated with permethrin can really help to protect you. And when the ticks get on the clothes, if they crawl up your clothes, they will die. So you can get this as a spray and spray it on your clothes and just let it thoroughly dry before you wear them. Or there are clothes that are pre-treated that you can wash some 20 to 50 times and still have an effective pesticide on them and be able to wear them for that purpose. If you come in from outside and you want to put your clothes in the dryer, it can take up to an hour at high heat to kill the ticks. So these ticks are very hard to kill. So wearing protective clothing is good. Deet is the insecticide that is preferred and has the most studies behind it. The US EPA says it's safe at all ages. Some other resources suggest not using it on infants under a year. The 10% Deet is adequate and does as good a job as any stronger percentage. The 10% will last 2 hours. The higher percentages just last longer. So you can reapply the 10% if you're going to be outside for a longer period than 2 hours. Another good thing to do for decreasing the risk of ticks in your yard, if you don't want to spray the yard, is to get what are called tick tubes. You can get these online. They're just small tubes with cotton inside that have been treated with permethrin, and you place them around the periphery of your yard, and the mice and chipmunks will take the pesticide-treated cotton and put it in their nests, and that kills the ticks on them so that they're not transmitting it. You just have to replace it every year. So this is a picture of these little monsters. If you look across the top, that's the size of the deer tick, and the ones all the way to the left is the nymph, and then you have the male and the female. The two over to the right are when they have had a blood meal. They don't have to look like that to transmit Lyme disease. The second one is the dog tick. It's much larger than the deer tick and has a little white around the carapace, the female does. The Lone Star tick is about the same size as the dog tick and has a nice little white star on its back. That's where it got the name Lone Star tick. It says it was first seen in Texas. They used to think it was only in Texas, and now you see it's across a third of the United States. The other one is another brown dog tick. The dog tick does not carry Lyme. It can carry Rocky Mountain spotted fever and tularemia, but it does not carry Lyme disease. The Lone Star tick now, there's been the first report that it can. So as you see, the ticks are tiny. The nymphs are the size of a poppy seed. So you realize how sometimes you think it's a little freckle, and then you realize, no, it's got legs. If you discover a tick bite, you may have old ideas in your head about ways to try to kill that tick. I know in the past we've been told to burn the tick, put Vaseline on it, put soap on it, all sorts of concoctions. None of those things are good ideas. What actually happens when you do that is the tick is more likely to inject its contents into the person it's bitten. So you want to grab it with a tweezers. The fine point tweezers usually works the best, and get it as close to the head of the tick as you can, and just pull it gently and steadily straight out. You may want to keep the tick and label it on who got bit on what date and put it in a plastic bag in case you want to send it for identification. The choice to send it for ID or not really depends on kind of how you feel about your relative risk. There's various estimates of what percentage of the ticks are infected, anywhere from 30% in the Northeast up to 50% in some areas. So if you're playing, statistics and you have a child who's already had Lyme disease, the recommendation would be to treat rather than not treat if you know that the tick was carrying Lyme. So you can send it to the lab and have it tested, and there's one website up there that does it, but there are many other places that will also test the ticks. Unfortunately, there is a charge for each disease you want to test in the tick. So it's one charge for Lyme, another charge for Babesia, another charge for Anaplasma. So it can get pricey in terms of testing the ticks. So the other diseases that the ticks carry are Anaplasma, Ehrlichia, Babesia, Bartonella, Mycoplasma viruses. Some of the reports are, especially people who are really sick with Lyme disease, probably at least 40% are carrying more than one infection. Diagnosing Lyme disease is a bit tricky. We do not have a perfect test. And so Lyme disease, you have to remember that it's essentially a clinical diagnosis with a lab as a helper. Not that you have to have a lab confirmation in order to think that you have Lyme disease. If you have if you have a tick bite and you found it and you get symptoms, that's easy. That's straightforward. You know to treat, and in all likelihood, you'll have a really easy course and not any prolonged symptoms. If you get the erythema migricans, which is the red rash that can occur within days to several weeks at the site of the bite, that, by definition, is Lyme disease. It is already the spread locally of the spirochete, and when they biopsy those lesions, there are active spirochetes in the lesions. So that is Lyme disease, whether you have a positive test or not. If you have, and it doesn't have to be, it doesn't have to look perfectly round. It doesn't have to have a clear space in the middle like the target lesion. We've seen them be anywhere from 5 centimeters up to 30 or more centimeters. They can be oblong. They can be many different shapes. So just to be alert to generally non-itchy rashes that occur and can last for about a week, and then they go away. About 50% of the people do not see the tick bite, and at least 50% do not get an EM rash. In Dr. Jones's 10,000 patients, he feels that about 7% report the EM rash. So it's different in different series. I think a lot of times people aren't looking in odd places on their body for rashes, and particularly given that they don't hurt, they're easy to miss. So you're always looking at the likelihood of exposure. Have you been somewhere where there's likely to be ticks? And your symptoms. Lyme is definitely the great imitator of our times, like syphilis was 50 years ago. The onset can be either abrupt or slow. All organs can be affected, and the symptoms can be vague, and they can change from day to day, which sometimes leads people to think the person is making it up, like you can't possibly have this symptom and then that symptom and then some other symptom, and every couple days it's a little bit different. So this is a list of the signs and symptoms of Lyme disease, and as I read through it, you'll see that there is certainly an overlap with some of the way that PANS and PANDAS can present. So it's a flu-like illness, fatigue not relieved by rest, headaches, which can be either mild or severe low-grade fever, dizziness, pain or stiffness, migratory arthralgia, myalgia, sleep disturbances, abdominal pain. Neurologically, there can be poor balance or coordination, hypersensitive to touch, sound, and light, mood disturbances, depression, anxiety, new onset of phobias, oppositional behavior, OCD, motor and vocal tics, less commonly Bell's palsy, optic neuritis, peripheral neuropathies. School-related problems are common, difficulty with concentration, attention, focus, word finding, short-term memories, social withdrawal, less participation. So then we get into the lab part of the diagnosis. And the way it's been set up by the CDC is it's called a two-tiered testing approach. The first tier, the first test, and what mostly the primary care and pediatric specialists will do is to do an ELISA test. And if the ELISA is positive, they'll follow that with a Western blot, which is more specific for Lyme. The problem with that is that the ELISA test, the screening test, which is supposed to pick up the incidence of Lyme, can be negative in up to 50% of the time. So if you're missing 50% of the cases and you don't move on to then running a Western blot, you can see where some of the confusion and the difficulties in terms of diagnosis come from. Once we get to the Western blot, most of the commercial Western blots have an IgM, which is your acute phase reactant, which usually becomes positive about 10 days after a bite to several weeks, and can peak at about 3 months and disappears at 6 months. And it has an IgG part, which usually doesn't become positive for a month and can stay high for months to years. And by CDC definition, you should have 2 bands positive in the IgM and 5 bands positive in the IgG. So I listed the bands that are very specific to Lyme that are on the Western blot, the 18, 23, 31, 34, 39, and 83, 93. Now, the 31 and 34 band are not on most of the commercial Western blots. Those are very specific for Lyme, but they were left off because when the vaccine was on the market, those were the bands that turned positive, that recognized, so that you'd know that you'd had the vaccine. So those 2 bands, it's felt, don't really become positive until you've had the disease for a year. So they may be markers for long-term infection. And they also are ones that may correlate more with HLA tissue types, DR2 and 4, and increased incidence of autoimmune reactions. The 41 band is not really specific for Lyme disease. Bacteria and spirochetes can create the 41 band. And all the other bands that are on there that CDC uses as part of the 5 positive bands on the IgG really have nothing to do with Lyme disease. So it's a bit arbitrary. And the other thing that's important to remember about the Western blots that are in the commercial tests that are available in the United States is they're all based on one strain of Borrelia. It was a B31 strain that was removed from the midgut of a tick. It wasn't even found in a person. And every test is based on that. And there's over 100 strains of Borrelia, and there's only 1 in the kit. So you can see where there might be some difficulty in terms of having a robust response to the proteins of that particular strain if you have a very different strain. There is one lab, IGenix in California, that does include 2 strains, so there's a little more variability there, and they also report all the bands in IgM and IgG, so you get a more complete picture. So even one specific band being present can indicate exposure. The more bands that are present, the stronger your diagnosis and the more likely that you've got Lyme disease, but sometimes you'll only find 1 band and you've got a strong clinical picture that may be enough to decide to treat. PCRs are based on DNA material, and there are those that are specific for Borrelia burgdorferi. If they're positive, it's very helpful. Unfortunately, Borrelia mostly is in tissue. It's not in blood. So the specimen from blood is only positive about 30% of the time. Doing the PCRs repeatedly and from multiple different samples, like looking at serum, whole blood, urine, cerebral spinal fluid, the more different places you look at it, and the more different times you look at it, you increase your likelihood of finding it. I just want to point out here that even in people who have clear evidence of central nervous system involvement, the PCR in the cerebral spinal fluid is positive only about 10% of the time. So having a normal spinal fluid doesn't necessarily mean you don't have Borrelia in the brain at all. There is a test that looks at the immune system. It's called the CD57. It has to be done in a particular way that LabCorp does, and now IGeneX also does. It can give corroborating evidence of a persistent Lyme infection. It's felt that if it's particularly low, it can correlate with persistent Lyme disease, and the sicker people usually have very low levels. It's not particularly useful in children, but much more so in adults. There's a new blood culture that's on the market this last year and a half that's been put out by Advanced Lab that looks promising. This is the first time we've really had a test that will tell us, do you have Lyme disease today? Because except the PCR would tell you that some too. But the Western blot just tells you that you've had exposure. It can't really tell you that you've got recovery, that you've totally eliminated the spirochete, or whether it's causing your disease today. But if you can actually grow it out of your blood, that's the kind of evidence that would be really beneficial. Now, generally, Lyme is very hard to grow, and here they're growing it for 8 weeks to begin with, and if it's negative at that time, extending it for an additional 8 weeks. So 16 weeks, but they feel that their test is around 94% accurate. So there's one peer-reviewed study so far published on this. We need more data and confirming it, but right now it is exciting to really have a test that we might be able to do a test at the end of treatment and really see if someone has really cleared the Borrelia or not. The sicker the patients usually can tend to make less antibody. 30% can have a negative Western blot. Now maybe that's because there's some myomotoi in there, that 20% might have myomotoi. Some people have postulated that part of the reason for a negative antibody response is early in the disease there might be so much immune complex formation that all the antibody is tied up that way, and after treatment, when the antibody level goes down, then you may see it. The sicker the person, the more likely that they are to have co-infections. The immune factors can also play into this, the genetic makeup, particularly the HLA tissue types. Biofilms are getting a lot more attention in the last number of years. Dr. Eva Shapi at the University of New Haven has done some really great work looking at how that impacts the spirochete. We know that the biofilms have existed in many different types of bacteria, and it's a way to create a community-like organization that really protects the spirochete and promotes its growth and protects it both from the immune system and from antibiotics. So when there's a strong biofilm within the body, the antibiotics may not penetrate it, and I think this is another aspect that is probably contributing to the persistence of disease, in Lyme disease, and part of the controversy about does it exist beyond the short stage. Some people, like Dr. Klinghardt, have postulated that the EMFs, the electromagnetic fields, are contributing to the virulence, and Dr. Bach talked about that briefly, because you don't have to live next to a cell tower. We're all carrying our cell phones, and almost all of us have wireless in our houses, and we have portable phones. So all of those things, we're all being exposed to electromagnetic fields 24/7, just from those things. The Borrelia exists in 3 forms, and that's been known for many years, and different antibiotics will treat different forms. So it's present in the spirochete form, it can lose its cell wall and still exist, and it can form a cyst where it's really impermeable to the antibiotics. So the length of treatment in an early infection, 4 weeks, is quite adequate for most people. I do want to point out that a lot of you may have had a tick bite and you go to your doc and they say, we'll give you one dose of doxycycline and that'll prevent you from getting Lyme disease if you do that within 48 hours of the tick bite. That study was really designed to prevent the EM rash, not Lyme disease. They only followed people for 5 weeks, and they didn't really count the people that clearly had symptoms of Lyme disease, but they didn't have an EM. So that's not good advice. You don't want to take a one-time dose. It doesn't protect you from Lyme disease, and in fact, it may just make it harder to have a positive Lyme test. So it can interfere with the immune system and make it more confusing. You definitely want to treat until all signs and symptoms of Lyme and co-infection are cleared. If the person's been ill for months to years before they ever get treated, then the treatment is a very different character and has to go on often for months to years. All the co-infections have to be adequately treated too. So these are just the categories of the antibiotics, the cell wall agents, the intracellular agents. The ones that are particularly good at cyst and biofilm are the antiparasites, the metronidazole and tinidazole. And Dr. Shoppy's group has also looked at two herbs, banderol and cemento, which are also used in Lyme disease, and that those two together have been quite effective at destroying the biofilm, as well as some of the enzymes like nattokinase, lumbrikinase, serrapeptase, and the grapefruit seed extract. So if you think Lyme disease testing is inaccurate, co-infection testing is even worse. When you're looking for Anaplasma, Ehrlichia, Bartonella hensling, Quintana, and Babesia microti and Duncani, there are antibody tests that exist for those. They're certainly not 100% accurate, and there are other strains that we can't test for. A blood smear can be done in Babesia if it's within the first 2 weeks. There is some additional testing that's available through IGeneX doing a fluorescent stain for Bartonella and Babesia, which is felt to be about 100 times more effective than the antibody test, or more accurate. There's a specialty lab, Fry lab, that's doing a biofilm stain and looking at hemobartonella-like organisms, and the Galaxy lab is doing PCRs and cultures for Bartonella. The symptoms of Bartonella, generally a gradual onset, occasional light night sweats, more central nervous system symptoms, and as I've listened to all the PANDA information over the last 2 days, the rages are another one that really fits with Bartonella. Being in a rage, I've had what I think is Bartonella rages where the kids are opening the car doors too and jumping out and going on for hours. So many things can do this. So more central nervous system, more acute anxiety onset than skeletal muscle things. A lot of gastrointestinal pain and problems, sore soles of the feet, particularly when you get out of bed in the morning. They can have a blood marker called vascular endothelial growth factor, which might be high. There might be rashes that can come and go. Some of them look like scratch marks. Some look more like stria. They can be kind of purplish red stria, and as you treat the Bartonella, that stuff disappears. Bartonella tends to respond to zithromax as well as the Biaxin, sulfa, rifampin, fluoroquinolones, and probably minocycline. Babesia, abrupt onset, marked sweats, might have more chest pain and chills. It responds to antimalarials, so very different treatment. Ehrlichia and Anaplasma are more likely to have fever and a knife-like headaches, might have low white count, liver functions elevated. Mycoplasma can do all kinds of things. It's usually there with the sickest patients and can be difficult to treat. So in the chronically infected patients, you really want to treat all three forms of the spirochete, consider other infections, support the detox, diet is important, check for heavy metals, pay attention to endocrine issues, sleep issues, pain, autonomic dysregulation. This is information that comes from some of Dr. Jones's work in the maternal Lyme, that he looked at 160 women with Lyme before and during pregnancy. If the woman was untreated, there was a 50% chance of the infection being transmitted to the child. If the woman was treated with one antibiotic, that was decreased to 25%. 2 antibiotics throughout pregnancy lowered it to 1%. And I listed the antibiotics that are safe to use in pregnancy. You also have to use prophylaxis if you're breastfeeding. But of those 160 women, 8 of the babies tested positive by PCRs of the placenta or umbilical cord and foreskin, and they were treated for 6 months with oral antibiotics and did well. So let's just realize we all need to keep an open mind about what we're treating, and that we're really treating the patient in front of us.